The next cluster of disorders we're going to take on is obsessive compulsive and related disorders. Overall, the disorders that fall into this category, which includes obsessive compulsive disorder, or OCD, body dysmorphic disorder, or BDD, hoarding, trichotillomania, and excoriation, are all unified by the presence of obsessions and/or compulsions. Given that, it's important that we define what these terms mean. So the technical definition for obsessions is recurrent and persistent thoughts, urges, or images that are experienced as intrusive and unwanted. Compulsions, on the other hand, are defined in the DSM as repetitive behaviors or mental acts that an individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. So let's look at some examples of what obsessions and compulsions might look like. Obsessions could involve things like repeated thoughts about contamination, repeated doubts, forbidden thoughts, thoughts of harm to oneself or others, and things or objects that need to be in a particular place or order. Examples of compulsions could be things like hand washing, counting, cleaning, checking, requesting or demanding assurance, or repeating actions or ordering. And the important thing to remember is that for all of the disorders that fall into this category, the obsessions and/or compulsions must be excessive, and they have to be either distressing and/or impairing in some way. So let's first go through the diagnostic criteria for obsessive compulsive disorder, or OCD. According to the DSM-5, in order for someone to meet diagnostic criteria for OCD, he or she can experience obsessions, compulsions, or both. So it's not necessary for someone to experience both obsessions and compulsions to have OCD. They could experience just one of these symptoms and still meet criteria. However, if obsessions are involved, the DSM-5 states that individuals must attempt to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action, for example, by performing a compulsion. If compulsions are involved, the DSM-5 states that the behaviors or mental acts must be aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. So the compulsions can't be arbitrary. They have to be used to cope with negative or distressing emotions, or have to be employed because the person believes they can prevent something bad from happening. And as I mentioned before, the obsessions and/or compulsions in OCD must be excessive, distressing, or must cause significant impairment, as evidenced by one of two things: either the subjective reports of the clients, or because the obsessions and/or compulsions are occupying more than 1 hour per day of the person's life. In terms of the epidemiology for OCD, the DSM-5 claims that about 1.2% of U.S. adults meet diagnostic criteria for OCD at some time in their lives. And although males tend to be diagnosed more frequently in adolescence, females are thought to be affected at a slightly higher rate in adulthood. And regarding onset, the average age of symptoms is about 19 and a half years, with a quarter of individuals exhibiting symptoms by age 14. For the remaining disorders that fall into the category of obsessive-compulsive or related disorders, which, as I mentioned, include body dysmorphic disorder, hoarding disorder, trichotillomania, and excoriation, we can think about symptoms as falling into 3 different domains: obsessions, compulsions, and common criteria. So let's start with body dysmorphic disorder. According to the DSM-5, body dysmorphic disorder, or BDD, affects about 2.4% of U.S. adults, including about 2.5% of females and 2.2% of males. The most common age of onset is between 12 and 13 years of age, with about 2/3 of individuals with the disorder experiencing symptom onset before 18 years of age. The diagnostic for body dysmorphic disorder state that in terms of obsessions, an individual who meets criteria for diagnosis will experience a preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or appear slight to others. In terms of compulsions, that at some point the individual has performed repetitive behaviors, for example, mirror checking, excessive grooming, or reassurance seeking, or mental acts, for example, comparing his or her appearance with that of others in response to the appearance concerns, and that the preoccupation causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. Further, the DSM stipulates that the appearance preoccupations are not better explained by concerns with body fat or weight in an individual with an eating disorder. The next disorder we'll talk through is hoarding disorder. And I know this disorder has gotten a lot of attention in the media with shows like Hoarders, so you want to make sure that you're paying close attention to the actual diagnostic criteria, because some of what's in the media is a little faulty. So first, the DSM stipulates that individuals who meet diagnostic criteria for hoarding disorder have difficulty discarding or parting with possessions, regardless of their actual value, because of a perceived need to save the items and the distress associated with discarding them. Further, the DSM states that individuals have difficulty discarding possessions, resulting in the accumulation of possessions that congest or clutter living areas and compromise their intended use. And finally, like all other disorders that fall under this category, that the obsessions and compulsions cause clinically significant distress or impairment. Now, in terms of the prevalence rates, the DSM-5 states that nationally representative prevalence studies of hoarding disorder are not available, in part because, unlike what you might think due to shows like Hoarders, the bulk of individuals who meet diagnostic criteria for hoarding disorder are actually very secretive and self-conscious about it, so people often go to great lengths to prevent others from discovering their hoarding behaviors. However, community surveys in both the U.S. and Europe suggest the prevalence rate might be somewhere between 2 and 6% of the population. Hoarding disorder is also known to affect men and women, but the differences across genders are difficult to unpack. Although women comprise the bulk of clinical samples, some epidemiological studies actually report a significantly greater prevalence of hoarding disorder amongst men. One thing that we do know is that although hoarding behaviors may first emerge earlier in life, between 11 and 15 years, symptoms appear to be almost 3 times more prevalent in adults over the age of 54 compared with younger adults, so those between the ages of 34 and 44. Now, like so many other disorders, the DSM-5 includes specifiers for obsessive-compulsive disorder, body dysmorphic disorder, and hoarding. And the specifiers that are included in the DSM are specifically related to obsessive thoughts. So because OCD, BDD, and hoarding disorder all involve obsessive thoughts, they can be specified as with good or fair insight, with poor insight, or with absent insight or delusional beliefs. When we say that someone has good or fair insight, we mean that the individual recognizes that the obsessive beliefs are definitely or probably not true, and that they may or may not be true. When we say people have poor insight, we mean that the individual thinks the beliefs are probably true. And when we say that someone has OCD, BDD, or hoarding disorder with absent insight or delusional beliefs, that's because the individual is completely convinced that the beliefs are true. The remaining 2 disorders that fall into the category of obsessive-compulsive and related disorders are slightly different from the previous ones because neither of them includes obsessions in the diagnostic criteria, just compulsions and common criteria. So the first of these is trichotillomania, which involves recurrent pulling out of one's hair resulting in hair loss, accompanied by repeated and unsuccessful events to decrease or stop hair pulling. As a result of these behaviors, the person experiences clinically significant distress or impairment in social, occupational, or other important areas of functioning. And the last disorder you should know about is excoriation, which is very similar to trichotillomania. However, in excoriation, the person picks their skin to the extent that they experience skin lesions, despite repeated attempts to stop skin picking. And like all other disorders in this category, for individuals diagnosed with excoriation, the skin picking causes clinically significant distress or impairment. Now, in terms of etiology, I know your book gives you a few different theories of why obsessive-compulsive and related disorders might come into being. However, the reality is that we don't really know. So, although some people think that thought suppression might play a role, and others hypothesize that obsessive-compulsive and related disorders might actually be adaptive in an evolutionary sense, more current research suggests that OCD in particular might best be explained by a combination of biological factors that might make someone more vulnerable to developing symptoms, and learning, in particular the two-factor theory, which we've talked about before. In terms of treatments, current research has supported the use of both medication and psychotherapy. The most common medication used to treat OCD are antidepressants, particularly clomipramine, which is a tricyclic antidepressant that works by inhibiting serotonin reuptake. For all disorders in this category, cognitive behavioral therapy has been found to be effective, and for those disorders that involve compulsions, cognitive behavioral therapy with response prevention is often the go-to treatment. Now, it's possible that Jim Seaman will talk about this in class on Wednesday, but if you're curious about getting some initial ideas about what CBT with response prevention looks like, there are episodes of a BBC show called Extreme OCD Camp on YouTube. Now, there are of course some issues with the presentation of OCD in this show, and you know that I'm not a huge fan of pointing you towards YouTube, but this show does give you some fairly decent examples of what CBT with response prevention looks like, so you should feel free to check that out. So that's your lecture on obsessive compulsive and related disorders. Remember that Dr. Seaman's going to be in class on Wednesday, so make sure you come prepared to listen and also participate. I'll see you then.